You never really appreciate your liver until it's not working, and it can go really, really far and be seemingly fine until it's definitely not, and then all systems down.
Welcome to Healthcare Perspectives, a podcast by Siemens Healthineers about medical breakthroughs with the power to improve lives everywhere. You've just heard Dr. Michelle Long, International Medical Vice President of Metabolic Dysfunction-associated steatohepatitis at Novo Nordisk, and Director of Clinical Research for the Section of Gastroenterology and Hepatology at Boston University. Here, she explained just how integral proper liver function is to our overall health. In this episode, Matt G., Director of Collaborations and External Engagement at Siemens Healthineers, is joined by Michelle Long, as well as Dr. Arun Sanyal, Professor of Medicine, Physiology, and Molecular Pathology in the Division of Gastroenterology at Virginia Commonwealth University, and Michael Battelle, President and Founder of the Fatty Liver Alliance.
Hi everyone, I'm Matt G. You might be surprised to learn that we're in the midst of a global pandemic affecting nearly 1/3 of the world's population. Metabolic dysfunction-associated steatotic liver disease, or MASLD, is a chronic liver condition that affects individuals worldwide. It's characterized by excessive fat accumulation in the liver. Risk factors for developing MASLD include obesity, type 2 diabetes, and metabolic syndrome. Genetics, unhealthy dietary habits, and a sedentary lifestyle can also play significant roles in its development. But this condition is reversible when it's caught early. Diagnosis of MASLD and MASH typically involve imaging examinations along with blood tests that assess liver function and often are performed by specialists called hepatologists. Disease management focuses on lifestyle modifications such as diet and exercise, though new medications are now being prescribed to slow and potentially reverse this condition. Regular monitoring of disease progression is also crucial for successful treatment. In this episode, I'm joined by experts in the field of liver disease to address the progress happening in the recognition, diagnosis, and treatment of the disease, and how earlier intervention requires empowering physicians who see patients earlier in the care pathway.
Among adults, 30 to 40% of adults in most countries have excess fat in their liver and have MASLD.
This is Dr. Arun Sanyal, a hepatologist at Virginia Commonwealth University.
The key risk factor for this condition is being overweight or obese. About 2/3 to 3/4 of the world's population are overweight or obese, and about 30 to 40% have MASLD. And that number is slowly creeping up.
Michael Battelle is president of the Fatty Liver Alliance, a not-for-profit charity that raises awareness and promotes education about MASLD. He was already deeply involved in the field of liver disease when he decided to undergo an evaluation on himself.
I didn't even know that I had fatty liver disease, and I thought, I'm running this organization, I haven't even followed my own recommendations and actually assessed myself. I had something called VCTE, and it turned out that it was what they call a CAP score of 319, which means that over 70% of my liver had fat in it. First of all, I didn't believe it, so I was like, there's no way that's true. I actually went to experts to say, can you look at my report because this seems really high, and I'm not living with obesity, I'm overweight, but I do have a lot of other metabolic issues going on that I'm controlling. They confirmed that's what it was, and then I set on this almost 2-year mission to reduce it.
Though Michael Battelle's diagnosis came as a shock to him, this sort of experience isn't uncommon in the world of hepatology.
In the late 90s, we started seeing a lot of patients with fat in their liver at a time where no one really knew exactly what was going on.
For Dr. Arun Sanyal and his team, identifying the relationship between a fatty liver and metabolic dysfunction was key to understanding MASLD.
We were the first to connect the dots between the fatty liver and insulin resistance, which subsequently then connected to diabetes, cardiovascular disease, and of course now the field of metabolic dysfunction-associated steatotic liver disease is one of the major causes of liver disease impacting human health all over the world.
MASLD can progress into a more severe form of liver disease, metabolic dysfunction-associated steatohepatitis, or MASH, which involves more severe fat buildup and liver inflammation that can result in fibrosis, cirrhosis, and ultimately liver failure. Liver dysfunction can also cause cardiovascular complications. And while the connection between metabolic dysfunction and liver disease is strong, it's also important to dispel the many misconceptions that surround these conditions.
There's a lot of stigma, and there's also a lot of mystery associated with the liver in the general medical community. First of all, it is completely incorrect to assume that everybody with liver disease somehow did it to themselves.
This disease is not just about poor lifestyle choices, which is a common comment, and it's not the fault of patients because they're making the wrong food choices. It's way more complicated than that.
For patient advocates like Michael Patel, the aforementioned name change signals a major step forward in the way MASLD is understood, especially within the context of metabolic disorders.
The nomenclature change calls out the metabolic involvement just because it's metabolic dysfunction associated, and it doesn't have to be a disease of so it's not non-alcoholic. It was more helpful to envision and understand the complexities of the metabolic involvement. So it provided for some patients the opportunity to really understand what the disease is.
The word non-alcoholic tells you what the disease is not due to. It doesn't tell you what the disease is due to. So that's why the nomenclature shifted. The prevalence, as the population ages with this condition, the proportion of people with steatohepatitis is increasing. The liver is a very forgiving organ. It won't tell you something is very seriously wrong. So many people early in the course of their disease do not have a lot of symptoms. The disease does not progress to problems within a day or two or a few weeks. It takes years to progress and create a problem.
As Arun Sanyal explains, while MASLD progresses in a patient's liver, it may be misdiagnosed or even written off by an underinformed medical system.
There's a general lack of awareness that there is something called fatty liver disease, even among the medical community. What is particularly sad is that there are many instances where there are already features of liver disease that are evident during clinic visits, but they are not really paid attention to. Many patients are told that, a lot of people have elevated liver enzymes, don't worry about it, it doesn't mean anything, till suddenly one day it's discovered that the person has cirrhosis. The patients don't know that there's something called liver disease. They don't really think about their liver. Patients know about heart disease, diabetes, but they don't really know much about liver disease. Most of these patients are relatively asymptomatic, so the only point of contact with the medical system is when they come for annual checkups, and that is with primary care.
For Dr. Michelle Long, International Medical Vice President for Liver Diseases at Novo Nordisk and Associate Professor of Gastroenterology at Boston University School of Medicine, the lack of awareness around MASLD makes sense when considering how recently the disease has made its way to the forefront.
This was a disease that I didn't learn about in medical school, but started seeing it on the wards. It was right around the time I completed medical school, so it was really very, very early days for the disease, and we're starting to hear about it and see it in practice, and not something you can go read the textbook on because it wasn't written yet.
And according to one set of research, the number of people both in medicine and the general public who are unaware of the condition is shockingly high.
About 25% of the people that they spoke to, including physicians and patients, are aware of fatty liver and MASLD. We need to increase awareness so that people know if they have any of these metabolic disorders, they need to get assessed for it. So awareness would be the first challenge that people have to deal with. People aren't aware that they have it, and it is, for a lot of people, a slow-moving disease until it's not.
Though many living with MASLD are completely unaware of their condition, Michael Patel argues that the idea of liver disease being a silent killer is actually a misconception. While the symptoms associated with MASLD may be common to many other conditions, they do exist and can be watched for, especially when they begin to compound.
I think it's not helping us by telling people that it's a silent disease. A lot of people share they have fatigue and low energy. There may be physicians that say, take a couple days vacation, you'll be okay. But that's not the solution for that patient. And you need to ask those probing questions to really understand that. Some patients go further and they have things like brain fog, difficulty concentrating. Even those symptoms can be attributed sometimes to overwork or exhaustion. But when they start to add up, it means something else is going on that has to be investigated. Pain and discomfort on the right quadrant of the abdomen might be due to liver inflammation, joint pain, muscle weakness, sleep disturbances, weight-related struggles.
At the Fatty Liver Alliance, Michael Patel and his colleagues work to educate both patients and physicians with the goal that liver disease will soon have the visibility of other life-threatening diseases.
We raise awareness through two distinct approaches. One is we go into communities and we bring in a specialist to talk about MASLD and MASH, fatty liver disease, metabolic comorbidities, how it all fits together, lifestyle. It will raise awareness not only with the people in the room and their families, because there's also a lot of familial disease that's related, but it'll also encourage and educate the physicians. The other way that we do is traveling around the world to liver conferences, and I meet with physicians and specialists and even caregivers, and we do these one-on-one interviews. I also summarize the talks so that people can understand at any level what it is that we're dealing with, how it progresses, what are the risk factors, what are the treatments available, and to really get people up to date with that.
And for Arun Sanyal, visibility starts with the medical community.
I think further engagement with primary care community, American Society for Family Practice, and the U.S. Preventive Health Task Force, these are important next steps for the field to increase awareness, change practice, and by doing all of this, increase access to care for patients.
Though getting patients to take the disease seriously can pose quite a challenge as well, education remains the key to awareness.
There's a lot of people that are saying, well, I have so many other things I need to worry about. This isn't bothering me. I'm not feeling sick. Why do I need something else I have to worry about? A lot of people are just completely unaware. For those people, this has not been going on for a short period of time. They just were unaware of it.
Liver fibrosis is a gradual stiffening of the liver caused by bands of scar tissue that reduce blood flow through the liver and restrict its access to oxygen and nutrients. Cirrhosis is said to occur when the scarring is largely irreversible and the liver is permanently damaged. As cirrhosis worsens, the liver begins to fail, leading to hospitalization and death. Similar to cancer staging, patients diagnosed with liver fibrosis are often staged to determine how far along they are in their disease progression. The scale quantifies the stages using something called the NASH Clinical Research Network, or NASH-CRN staging system, and ranges from F0, no fibrosis, up to F4, cirrhosis of the liver. But this staging requires a biopsy, which is not practical in real-world situations.
Clinically, that's not how we diagnose the disease. Typically what happens, you have a patient who maybe has elevated liver biochemical tests for some time. You take a history, they don't have a history of alcohol use or other liver problems. Then you might do an initial workup of those abnormal liver blood tests. You get imaging, like an ultrasound, and that could show there's fat in the liver. And then you typically rule out other causes of viral hepatitis, other autoimmune liver diseases. And when you don't have another answer, and in the right clinical context, then you have a high suspicion that the patient has MASLD. There are other tests then that are typically recommended. A first-line blood test that is called the FIB4. It includes your age, the liver biochemical test, AST, ALT, and your platelet count. And depending on what the value is of that score, you may be at low, indeterminate, or high risk of having more advanced fibrosis. Typically, the recommendation is to get a second test to better understand what's going on. So in practice, liver biopsies typically are not used because we have also learned that if you have someone who has the metabolic risk factors and they have a predicted risk of fibrosis, then you have already what you need to make a clinical diagnosis of the disease and potentially even start treatment.
While clinicians are increasingly moving away from biopsy for diagnosis of MASLD and MASH, some are questioning the value of linking non-invasive test results to fibrosis stage altogether.
We need to change the conversation, less around what particular stage of fibrosis do you have, and more accepting of what is your risk of having a subsequent event. If we can accept that what we're trying to predict in our patients is who is at high risk of having a liver-related event, who is moderate risk, and who's low risk, we already have quite a lot of data, and it will simplify things because it doesn't really matter if this one predicts that you're F2, this one predicts you're F3. If you're having some concordance of NITs, putting you in a risk category that is much more approachable from a clinical point of view.
With a better understanding of liver disease and the possibilities for treatment, the tools used to assess the disease have become increasingly less invasive. This is a benefit for patients that is top of mind.
When I was first doing practice, I used a lot of biopsies because we were all trying to understand the natural history of disease before we had wide access to NITs, non-invasive tests. This is how it was done. Biopsies are used still in our clinical trials. And then typically clinically, if you are unsure in this diagnostic workup, there's other things that come up. Perhaps there's a suspicion that there could be an overlap condition and you're not quite sure what's going on. That's usually the clinical context where you get a biopsy. Even in the setting, for cirrhosis especially, if you have non-invasive tests, blood or imaging tests that suggest cirrhosis, then we don't even typically get a biopsy to confirm cirrhosis because we can rely so much on our non-invasive tests. I also wouldn't feel comfortable as a clinician subjecting patients to biopsies, understanding the risks involved with them, and knowing that I already use tools in my clinic to help avoid them for patients. It's important to understand that practice has evolved. I can bring that in from my clinical experience into Novo Nordisk and how we do our trials and how we think about the future of doing trials.
And with non-invasive tests more widely available in clinical practice, access to care can improve for patients. For both Michael Patel and Arun Sanyal, the most successful sort of testing is the kind that is easy to undergo and to administer, making it more convenient for both patient and provider.
A lot of remote areas, they can't get the scanning that they need done. They have to fly. And even if they're close by, often people have to wait months to get the most commonly used right now. There are other options available, and the non-invasive testing is a really big part of it. Really, nobody is advocating anymore for regular biopsies. It's not something that people want.
In terms of non-invasive tests, the more you can do where the patient is seen in primary care, the better it is. These are patients who are not having a lot of symptoms, and making them go from physician to physician to get different types of tests probably will not have great uptake.
That's not to say that non-invasive testing is ready to completely replace biopsies, though the future does look promising.
I think we need more outcome data. I'd like to see more NITs linking into outcomes and less into specific fibrosis stages. We need to better understand across different potential mechanisms how the NITs work. Also, at what point in time can you see a change in a non-invasive test? And is that predictive of a durable response or result? And the magnitude of change that we should be looking for.
With the advancements made over the past few decades, both understanding and treating MASLD, the future looks promising. But of course, there are still major hurdles to overcome.
We need to engage in studies that formally and prospectively demonstrate that in a general population, if you screen for end organ disease and you get a handle on the metabolic health of the population, and that people who demonstrate evidence of being metabolically unhealthy and have relatively intact organs, that if you intervene at that point, which is the lower cost an easier intervention that compared to no intervention, you are actually reducing end organ disease. You're reducing the number of people who have to drop out of the workforce because they get disabled from metabolic end organ diseases.
For Arun Sanyal, one of the biggest obstacles remains the lack of awareness from physicians and the healthcare sector in general.
We have to start increasing awareness within the physician community. We need to make sure that people have access to these kind of diagnostics so that insurance companies pay for these tests. And the results of these tests should lead to clinical decision-making that will benefit the patient. If we know the patient is at increased risk and meets criteria for drug treatment, and there are now approved drugs for this condition, then they should have access to those drug therapies.
From a pharmaceutical point of view, Michelle Long believes the future treatment of liver disease lies with the idea of non-invasive testing taking precedence.
We need to move away from the biopsy. I mean, that is a critical part of the future of drug development. It's going to be uncomfortable because it's not like we're able to fully validate any of the non-invasive tests that we're talking about right now. But I think as we learn more in the next couple of years, as more trials results, I think it will become even more clear that the way that we're doing trials right now is not sustainable, and it's actually holding us back. And it will be even harder to conduct trials like this in the future, especially because you can treat patients already without having a biopsy. We have the tools there. It's just a question of framing. We're already starting to see improvements in some of the language. If you look especially at the latest practice guidelines from EASL, this is the European Society for the Study of Liver Disease, already they're talking a lot about risk, and they're talking about fibrosis and not so much about MASH. Even that language itself just already takes you out of a biopsy context, which I think is really important. But we need to make it even simpler for the practicing nurse practitioner or general practitioner to understand. And then a lot more nuances around how do we monitor patients? What does a treatment failure look like? These types of questions are kind of the next phase.
And for Michael Patel, the goal of the Fatty Liver Alliance is to educate the general public about MASLD and create awareness for those at risk.
We've done community events assessing a group that had no idea. They just came in because they wanted to hear a talk about if they have any disease. We're doing scans, and we're finding a lot of people who have already advanced disease. In the last one we did, we had 60 people that we assessed. 4 people had very advanced liver disease that could be cirrhosis. They have to get retested again in a more clinical setting, but a lot of people are just completely unaware.
But it's not just about creating awareness for those who are vulnerable to the disease. It's also about educating patients and physicians alike about treatments and lifestyle changes that can lead to a successful fight against a fatty liver.
I think it's really important to know there's a whole menu of things that you could do to help with your liver disease. If we're trying to avoid long-term chronic diseases, we need to stop it in its tracks. And I think there's a lot of tools available. So if anyone in industry is creating those tools, make them available or affordable so people could use them, even for short term, 10 days at a time, something like that, so that they can try them out and learn about themselves.
Though a diagnosis of metabolic dysfunction-associated steatotic liver disease may be an unnerving one, there are ways to reverse course. With proper management, patients with fatty liver can greatly reduce the risks the disease poses to their health. Through increased visibility, the rise of non-invasive testing, and greater understanding amongst physicians and patients alike, MASLD diagnosis and treatment will only continue to improve moving forward.
We already know that almost half the population has at least the beginnings of liver disease. You are not alone. Use the resources you have available. Go to credible online support, join a group, talk to your spouse. Don't be afraid to talk to your employer if you're struggling with getting to appointments. You have to take care of yourself. Nobody else is going to take care of you the way that you need to take care of and advocate for yourself.
You have been listening to Healthcare Perspectives, a podcast by Siemens Healthineers. We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. Subscribe to us and always get the latest episode in your podcast feed, or visit siemens-healthineers.com/podcast for more. The opinions expressed by the guests and contributors in this podcast are their own and do not necessarily reflect the views of Siemens Healthineers. The statements by Siemens Healthineers customers in this podcast are based on results that were achieved in the customer's unique setting. Because there is no typical hospital or laboratory and many variables exist, for example, hospital size, samples mix, case mix, level of IT and/or automation adoption, there can be no guarantee that other customers will achieve the same results. This podcast describes possible future ideas and concepts. It is not intended to describe specific performance and/or safety characteristics of currently planned or future products. Future realization and availability cannot be guaranteed.